promote consistency, especially in the inpatient team, that we're all using this similar evaluation, kind of like PTL does the BIRD on people. I want us to all be using the BIVABA as part of our starting point for vision.
I'm gonna peek, Lori, because Kate will have no clue.
Okay, yeah, go grab
Come
them.
to.
Would you want me to go out there?
Oh, if you want, and then
And-
that way, because I was gonna say, she'll have no
And
clue where to
there's
come.
Joe Tucker too.
Okay.
Yeah, big curly black hair.
Okay.
So the reason vision testing is important on inpatient, also on outpatient, is it's our most far-reaching sense. People rely on their vision when it's impaired, like me in that stimulation room. I was relying on my vision mostly to try and find something. I didn't find it. And when it's impaired and distorted, they still rely on it. So it's really important for occupational therapists to evaluate vision loss and help patients adapt. This is my Lori Galicki APA format. It's not really according to what you learn in school, but it's been a long time since I've been to school, so I wanted to give credit to Mary Warren and Glenn Gillen for this presentation. And really looking at, I don't know, like when you went to school, Susan, just to pick on you, because I know we're the same age. Did you talk about this triangle and Patty?
I have
did you?
no,
No,
never
nothing.
seen it.
Okay, so this is just really talking about vision as a kind of a bottom-up approach that each of the different visual skills kind of builds to the next skill. So, you know, you have your ocular motor control, visual fields, visual acuity, you know, attention, alerting, scanning, and all the way up to the most complicated thing. So when I went to school, way back when, I mean, we would just test people. We would never check acuity. We were never trained in that. We'd go straight to the MVPT, and that's really the top level of assessment. So when you assess at the top level, you may not know why they did poorly in figure ground. You may not know why they did poorly in other areas. So it's really that bottom-up approach. So they're building blocks for any, come on in, have a seat.
Okay.
It's all right, it's informal. They're building blocks for the higher levels. If you have deficits at the basic levels, it's really hard to determine what higher level skills are truly impaired. And then looking at a top-down approach would be starting with MVPT or trails A and B, or even assessing ADLs. That's a more complicated skill. You know, wayfinding, reading a map would be the most complicated. Reading a home exercise program that their hand therapist gives them would be a more complicated one. Then, again, it's been a long time since I went to school, so I just wanted to bring in the term ecological validity. So it's really the term that is the functional and predictive relationships between the patient performance on a set of tests and the patient's behavior in a variety of real work settings. So we want things to have a high ecological validity. And again, I think in occupational therapy, since our basis is occupation and function, we want it to be functional, our tests. And this is just a little snippet directly from Glenn Gillen, and I was going to bring in a copy of his book. I would highly recommend it, you know, for home care or
Who is it? Glenn?
Glenn Gillen, and
Gillen?
in your
It's in
packet,
here?
it's
Okay.
in there. The picture of it is. I meant to bring it in, but I
Okay.
forgot. But he is I just feel like he's the OT I'd always want to be. He's gone to the research. He looks at everything and kind of assesses it. So, and the book is very useful when you have like a stroke patient if you're trying to figure out what to do with them. And he was just talking about that pen and paper or tabletop assessments are really deficit specific, and they're kind of contrived and non-functional. You know, doing geometric shapes and forms or pegboards or body puzzles. You know, they don't really necessarily have a high ecological validity. They really have a low validity to terms to performance. That's why I always get, when I do the driving assessments, we do trails A and B, which it's fine and dandy, and there is some relationships between doing that and driving, but really there's nothing like getting on the road. It's a lot. I can't say doing these 2 paper pencil tasks, oh, you can drive in Ann Arbor. I just feel strongly that you can't say that. And then, you know, does the ability to sequence those series of picture cards predict the ability to plan, cook, and clean up? And then does failure to complete like a 3D puzzle really predict how they're going to do on dressing? So again, I'm just trying to, in this new year, to promote function and really go to the core of OT, because, if we don't, other people are gonna take our profession, So that's where I'm coming from. So these are just some examples, and those are in your handout of different paper pencil tasks, and then functional things. So, I thought it was kind of like repotting a plant, reading a menu, managing medications could even be used for hand therapy people, because those dang things are so hard to open, So really the results of a good evaluation are identifying limitations in occupational performance, and they are identifying factors or deficits that contribute to occupational performance, and that help us decide about our intervention. And then decide if an intervention is gonna help with the outcome. So this assessment that I'm gonna go over, and I'm only picking 3 subtests of it, is the BIVABA. It was something we purchased probably, how long ago, 5-6 years ago, and we do use it a lot, and I think it's been helpful with patients, and it's from Mary Warren's work. The last 20 years, she's been very instrumental in OT and vision, low vision therapy. So I'm just gonna skip to the next one. So I'm making it a new expectation that, not for you home care and hands, I can't do anything about you guys, but would encourage you to use this as a starting point to evaluate our primary visual skills in patients. Again, to promote that consistency. We always know the PTs are using the BIRD. Well, I wanna know that the OTs are using the BIVABA. And also, if we need more complex vision testing, we really, again, need to use we have new equipment that's been sitting there that hasn't been used. We have our new Keystone. That could be, it's pretty similar to the old one, you just need to practice with it. I think I'm kind of competent in it now. And then we have a new MVPT, it's a longer test, but again, it's very similar to the old one. I just think we should be using new stuff. So I probably preaching to the choir. But there's at least 3 locations for the paper packet. In your packet, you have one that's a PowerPoint presentation, and then you have one that kind of has a bunch of stuff. Yeah, that one right there. That handout sheet has in there. So this is the one we're going to be using when we do the competency. We have them in 3 locations here at the hospital. There's one in the file in the gym. You can pull out that drawer. There's one in the vision room, and there's also some up on the 2nd floor in the stack of the wall files. Any of the larger materials are in the vision testing room, which I can show you on the way out if you don't know where it is. And then some of these alternate testing cards, I'm gonna just leave in the vision room because it's hard to know where they're at, and usually you're in a vision hurry around here. These alternate ones, so going fast, 2 minutes. Oh, good, not too bad. I'm gonna go to the previous really quick. Yep. And I have 2 sets of eye charts. I don't know if home care would want to purchase a set of eye charts.
I don't know what Lisa purchased. She purchased something with Liz, but Liz hasn't done anything with it yet. So
Maybe
I was
she bought
going
the whole
to.
test?
Yeah, she bought like a whole box full of.
It's
and
a
I'm
really
wondering
good
if it's
test,
this,
and
so
it has it.
I really need to make time to get in there and do it.
And it's pretty easy, and we found that we like the way that I had a former student organize the handout, because if you look at Mary Warren's, she does a wonderful job, but the eval is like 20 pages long or something, and you just don't have time to do that.
Yeah. So we may have.
That'd be good.
We have something.
Okay.
I'm not sure what it is
Perfect.
yet.
So, go to the next one. So visual acuity, I'm gonna just do a quick demo. I guess I'll do it on myself. And then I'm gonna have like 2 people do it at a time. And then the same thing there's for the other assessments. So I think we should be able to get through that in 15 minutes. First one is, according to Mary Warren's test procedure, she wants you to test each eye individually, but I tend to test, both eyes together, because again, we don't have the time that we used to. And then if they're having double vision or couldn't see something, then I might go ahead and test each eye individually. So the directions are in your packet, and when you're learning to do the test, I just recommend you read them. So I'm going to check how well you can see by having you read out loud numbers to me on this chart. please hold this card and read the sentences out loud to me by beginning with the sentence at the top of the card. You know, here. Some of these sentences are pretty silly. You can turn your head side to side, but you can't do this, okay? So, and then you just read it below, and they're goofy sentences like, the gold dish has gray stripes, Carrie shouldn't shake the juice, she cannot change the picture, and so on. So it's pretty easy. If patients make more than 50% errors, which it's all kind of spelled out in your handout, so let's say I got one word right on the line, I probably wouldn't count that line, I would go to the line above it to count their accuracy. So the far vision chart is very similar, so I think we should get through these two really quickly. Again, you have these, and I have had patients that can't read that, so if you can't read this, you can't do much, you know. I usually will start on this side, because most of our patients, and sometimes I'll even, if I get a sense they don't have much trouble, I'll start down here. But, you know, again, this one you might need somebody to hold it, and then I kind of use this as my reference point. Again, this is designed to do one eye at a time, but for time factors. So then you're gonna have them read the line that they most easily read. If they get 50% or less, you're not gonna count that line, you're gonna go to the line above it. So that's pretty easy. So I don't know if we wanna just go through, well, let me show you all the assessments and then we'll come, just trying to decide, you'll be my test case to see which way is the best to do it. So other things to keep in mind for this group, if you have somebody that's aphasic or does not understand directions, I mean, if you're not getting consistent to close their hand or open the hand or wash their face, I probably would skip these altogether because it's gonna be a long process and the information you're gonna get is not accurate, but we do have other alternate tests that are shapes along with a matching card to go with them, or even just for some patients that you're pretty sure that they're consistent, they just can't vocalize it, we made up these little things for the numbers or letter chart. So again, I make sure that I'm getting some consistency, otherwise I kind of skip it and just rely mainly on observations. Ooh, I'm going
Yeah, I think you just bumped your
tooth slides
mouse
ahead. So the other thing I want to tell you is we have this book, and I'll keep it in the vision folder on the cabinet, and in it, the next couple slides are just copies of some interpretation information that apply to the assessment. So I kind of tagged, like, what does it mean, for example, and this might be a quiz question, if they if they mistake an 8 for a 3 or a 6 for a 5, couple of things it could mean. It could mean that they lack the visual acuity to see the number. Or it could be, if you think about the 8 and they're only seeing one side of it, it might be like a neglect. You don't know for sure, and I guess that's the point of bringing up Glenn Gillen's approach versus Mary Warren's approach, is you gotta kind of do some of both. You might have to do some of these contrived tests, but you also need to look at function. So, okay. These next ones I think are a little bit more tricky to do, take a little more practice. The visual field test for this one, do you mind being bone victim and putting on, you need an eye patch to do it.
I have visual problems, you really want me to be your test?
I don't care, I have visual problems too, like convergence issues, so. Okay, so you're gonna see how that little guy on the picture, so now I've got her, I always have to think, I've got her left eye occluded. Again, the directions are in your cute little book, which I have to refer to, because I've lost mine. All the excitement, it's more towards the back. And I'll say, I am going to present you with these targets in different areas of your visual field. I will be showing you either 1 dot or 2 dots, and you are going to tell me the number of dots that you see. It is very important that you keep your eye focused on my eye, because I'm going to sit right here, and try not to look for the dots. If you move your eyes to look for the dots, the test is not accurate. again, if you look at the top of this, it says you want to do it in a well-lit room. You want to be about 1 meter from the client. And it says eyeglasses off, but I kind of do it whatever they feel comfortable with. I mean, you could block a little of your vision with this, but for me, I feel like handicapped when I don't wear my glasses, so. So you kind of turn and face me. And then I like, because I have pretty long legs, I kind of just go knee to knee with the patient, and usually that's pretty close to 1 meter. And then I'm going to, it's a little cognitively challenging for the therapist at first to do, and it takes practice, but just try it.
So I'm supposed to look at your eye?
Yeah, so go ahead and look at my eye.
Okay.
I'm gonna show you either 1 dot or 2 dots. Let me know what you see, okay? And you're gonna do fine.
Oh, well, we'll see. 2. 2.
And if you think the person is, kind of guessing,
2. 2.
okay? And then the one in the middle.
2.
And you're easy, because you're good, but patients sometimes will miss that. And then you're gonna just take the time. This is the tricky part where you have to kind of record it. And I would go much slower if I was doing it on an actual patient. And I could mix it up,
Oh, okay.
if I think they're cheating. So, but if they're moving their eye all around and they can't follow your directions, try it a couple times, but then I would kind of not go too much further, because you're not really getting a lot of accurate information, so. And then you'd switch to the other eye. Who wants to be my next victim? And who wants to be a helper? Because you really need 2 people for this next test, which if you flip the page, it's the next one.
I'll be your helper.
Okay, so if you wanna,
I can move over.
yeah, so you could pour. And this one you've done probably,
This is a good one for me to review because I actually prefer the old.
right.
I just like that one.
Okay.
But, so I do need a review of this because I like to use
So
that one
this one,
more.
again, one examiner is gonna sit across from the patient, so I'll be the one sitting across. And one is gonna be about, behind the person in the pen light. And it says to have the room a little dim, but I think this is fine, It's hard to find a room perfect. So I want you to go ahead and look at my target. We are going to use 2 people to give this test. I'm gonna sit in front of you and Patty's gonna sit behind you. While you look at the target, as soon as you see the light from the pen light, please raise your hand or say now. It is very important that you keep your eye focused on the target that I am holding, and try not to look for the light. I'm gonna be watching you to make sure you don't cheat. Okay, because we want the test results to be accurate, so. Okay, and you're gonna wanna make that about 18 inches away from,
Okay.
and we put the light on, yeah.
Okay.
And so you're gonna, and really think about it, she probably should, whoops, you're cheating.
Can't help it.
And she really shouldn't probably see it till about here, because she's got that eye patch.
at the light, Lori.
Oh, I'm sorry, we discovered that too, patients who are impaired, use your eye.
And they look at the reflection in your
Yeah,
eyeglass.
so that's good. So if everybody in the room wants to close one eye and see when you can start to see that, is kind of where, I don't think anybody here, oh, you cheated a little bit. And then you bring it from your head down.
How do you do the underneath
That one.
Yeah,
Most
they always
everybody
can see
sees it,
that one.
although I did have a patient recently that could not see it until it was like right here. He had some definite
Yeah.
field impairments. Because this one's hard because you're trying to trick them. I usually go on the side that's patched and try and bring it up here, but you're gonna see it
So
probably.
do you not use the other one anymore? The old one? Like,
I tend not to.
you have it, you just don't
We
use it.
haven't. Again, I'm just trying to be consistent.
Right.
But how do you feel it's different results? Like the reason I like that is you can do it yourself.
Right.
And I feel you can really, I don't know, I feel like it's an equivalent test, but if you feel differently.
Well, I'm just trying to get people to do it in a similar fashion.
For
so.
inter-rater
Okay.
reliability.
Yes, thank you.
And then one
Right,
more
right.
question about that is,
one thing that because I'm used to doing peripheral this way, but one thing I can see that it does by having two people is the person in the front
Right.
can make sure that their eyes
Not
aren't moving.
cheating.
And when you're doing it yourself, you can't necessarily
It's hard
ascertain
enough to not,
Mm-hmm.
right.
Okay, so if there's not two people available
You-
though,
you
is it
could-
acceptable to use the other one?
I
And
think
note it on the form?
I think that's
Because
acceptable.
there are times where you just don't have a second person.
Right, and you could even use family member to be a target, they could be the first, they could be me
Mm-hmm.
and say, cause you know, even you who don't have any,
I know.
doesn't have any impairments except for her knee. So, well, why don't I break into groups, I think we can just do the acuity pretty quickly, we have like 5 minutes to do this, so I knew I was being over zealous in my thought of getting everything done, but if people, like, you can do the